We're going to talk about a very, very important topic about small for gestational age babies and particularly what happens to them over a long term. Now, we all know that there are a lot of short-term implications which are there in SGA, particularly with regards to hypoglycemia, with regards to perinatal issues, but there are a lot of long-term issues, especially with regards to growth, with regards to development, with regards to puberty and obesity, which are there. So today we are going to go through a lot of these issues and try to focus on key aspects of evaluation and management. And as in many parts of pediatric endocrinology, we need to have a careful mix of regular evaluation and preventive measures to avoid long-term complications. There are a lot of implications, particularly with regards to growth, and we'll see how there is a dichotomous pattern in terms of when one group of individuals will grow a lot and that will cause more metabolic complications, while the other may not grow at all, resulting in short stature and other complications which are there in that regards. So we'll discuss about that in detail. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information about pediatric endocrinology, including courses in pediatric endocrinology. And we have recently launched our book, which is available both as a paperback as well as a Kindle version. Now we've discussed about growth. The next issue, of course, is puberty. And we know that puberty is very important regulator of growth. What happens in SGA is that you have got a insulin resistance, which is very common. And this insulin resistance is going to cause both ovarian as well as adrenal hyperandrogenism. So they will have a higher risk of developing premature pubarchy as well as PCOS subsequently. There could also be an effect as discussed on the adrenals, causing early pubarchy as well as early puberty. So all these changes happen. To address them in much more detail, we've got Dr. Proteek who will discuss and dwell about these parameters.
Thank you, sir. So my topic for today are the pubertal issues faced by us in a child who has SGA. Till now, we were discussing at the time of neonatal or what can we do. Now, this is where these patients who may not know or may not have focused upon whether they have SGA or not, they come to us. And we need to ask them whether this child was SGA or not, so that we can become more vigilant about the issues. So we'll be discussing the topic with the following subtopics, that is pathophysiology, how the patterns of puberty are in SGA children, and how do we manage it. So the individual, we begin with the pathophysiology. Sir has very well explained, just a brief recollection, that the SGA children have a rapid postnatal growth, and basically it's the high insulin and the high IGF-1 levels. Now we know what happens with the GH axis, but what really happens in the androgen axis and the adrenal axis is that the SHBG levels decrease, and high LH levels, because of probably early pubertal timing, lead to increased adrenal androgen levels or probably ovarian androgen levels, leading to increased peripubertal adrenal androgen secretion. Now they have a higher risk of developing PCOS, that we know, but the main thing is this: during peripubertal time, the androgen levels are at higher levels. And what has been seen is that they have high DHES levels, high leptin levels, and low adiponectin levels. This is during that 8 to 9 year pre-pubertal age group, and that is very important. So the various patterns, and the most important is that of precocious pubarchy or adrenarche. So why is it really important? It is because this precocious pubarchy leads to an accelerated bone maturation. This causes premature peak height velocity, premature fusion of growth, and ultimately a reduced adult height. So what has been seen in various studies is that SGA girls who display rapid weight gain during early childhood, they have seen to have this premature adrenarche pattern. Now, this is very important. SGA children, being SGA is an independent risk factor. Apart, if you even separate SGA with prematurity, SGA with obesity, just being SGA is an independent factor for premature puberty, and being obese or premature worsens that possibility. This is an important and very important fact, is the children born SGA were on an average 4 centimeters shorter in one study which was done. So that it was 4 centimeters shorter than at the onset of puberty than children without any perinatal risk factors. And finally, one important point which makes us, the pediatric endocrinologists, the pediatricians, and we should be more focused about it, is that this hyperandrogenism actually disappears by early adulthood, which brings into the account that we should be more vigilant about this, and it is our duty to look whether they were SGA or not. So a cohort study, the A1 longitudinal study, it got out some. It was in the Bristol Journal, and it got out some important facts. It showed that the adrenal androgens, DHES level at 8 years, were inversely proportional to the birth weight and length. This association was stronger in girls. And why? And the most important part is the LBW and the rapid weight gain is actually a predictor for central adiposity and final height IGF-1 levels.
So what they're trying to say is that those who have a rapid catch-up
Yes,
are
sir.
more likely to have an early puberty.
Yes, sir.
But even those who have not catch-up, we tend to see a lot of early puberty happening in
Yes,
that.
sir. So, and a very important point is the onset of puberty. So, various studies have given the following information. The pubertal onset occurs earlier in children born in SGA than AGA, but the timing appears appropriate for chronological age and height. So, this may be a reason why they are actually ignored. They might consider it is coming in normal time, so we will ignore it, but it is actually, as various studies have shown, they are significantly earlier than in AGA levels, even though they come at the normal stipulated level of normal. I mean, it's not premature, but if we study them side by side, they're significantly earlier than in AGA children, shown in this study. Now, what is the important relation of SGA with menarche? Menarchal age is usually earlier or within normal age. Another study showed that menarche occurred within the normal range, but it was again like adrenarche, it was significantly earlier in the SGA group. And this study done in an Indian cohort very significantly shown that menarche occurred 6 months earlier in preterm AGA and a very important 12 months earlier in SGA children. Uh, so in puberty, oh, okay. Okay, this is coming. So one important point about the management of these children is that the management, as we know, can be pharmacological and non-pharmacological. And I would like to stress upon the non-pharmacological bit, which is quite ignored. We should be highly vigilant about children who are increasing that overweight or rather than obese point of that point. And we should ask them whether there was a history of SGA or not. So because if we compare an SGA child, even the adiposity, which is not as bad as an obese child, will have the same metabolic implications as an obese child will have who was not SGA. Because their capacity to contain that adiposity is much lesser than an AGA child to contain that amount of adiposity. So children born SGA who have had catch-up growth and normal height prognosis, a rapid weight gain in body weight and accompanying visceral adiposity are associated early and rapidly progressing puberty. And hence, it is up to us, the pediatric endocrinologists, the pediatricians, the gynecologists, to be hyper vigilant about these cases, about increasing weight and waist circumference. Metformin, yes, metformin has also been implicated in the use in these SGA children. It basically decreases the central adiposity, insulin resistance, and IGF-1 levels, and has led to reduced weight gain. As shown by this study, the New Horizons of Short Children Born, very important implications. Basically, metformin treatment for at least 3 to 4 years delays menarche by 1 year, and it prolongs pubertal growth, and also augmentation of final height is there. So it is a wonderful drug which can be used. Now, what about the use of Gnrh analogs as per what is used for precocious puberty? So this study done in adult height in short children born SGA, it said that Gnrh analogs are helpful, and if they're used with growth hormone, and if we use it with the growth hormone at a slightly increased dose of 2, it is definitely child who remains short at puberty at onset could definitely benefit from the combined GH and GnRH analog treatment. So as a take-home message, at least we should keep in mind that we should be vigilant. Any obese child who comes, we have to ask them whether there's history of SG or not. Be vigilant about the complications, look for premature adrenarche and act accordingly.
Age of metformin in the SGA cohort?
It was pre-pubertal. We'll talk about the study again. So basically, this is very, very important points which Proteek had talked about is with regards to how it is important to understand whether a child is SGA or not when they come to us with precocious puberty. If they're coming to us with precocious puberty, always look for that. If they're coming to you with PCOS or any metabolic complication, look for that, because this will happen at a much lower weight as compared to that, and this we'll discuss subsequently. Now, what about this case? We have an 11-year-old boy, birth weight was 2.4. Now growth concern, height is 122, very short if you see out here. And pubic hair is stage 3, testicular volume is 6. So this child is short and he has entered puberty. So this is not theoretically in the sense precocious puberty, but already the child is short and entered puberty. This is a major problem which happens, and this causes confusion because the bone age is 12 and a half and the expected height will be quite low in that perspective. So what do we do in that setting? So as discussed, this is clearly a triggered early puberty. We have to do something, and Gnrh analog could be an option in that perspective. And this is one study which we looked into, the randomized trial of Gnrh analog till final height, which shows that the height predictions of these individuals improved with Gnrh analog. So if there is confusion, you can give Gnrh analog in that perspective, and that could be of benefit in that regards. Now we have a 6.5-year-old girl, birth weight 2.1, not very short, height is 110, within the range. But what we see that she already had a stage 3 pubic hair development and DHEA is high. This is a classical example of precocious puberty. So what will you tell Naveen to their parents about long-term issues in this girl?
So in this, we need to watch out for other parameters of puberty, breast development.
Yeah.
And also, she's tried to reduce the weight if possible, because considering the SGA factor, she should not be, she not gain any amount of weight.
So this is basically a marker that there is insulin resistance, and the first manifestation is precocious puberty. So we have to look for possibility of metformin. This is one. But more importantly, long-term risk of type 2 diabetes, NAFLD, PCOS, all those problems will happen. So we have to be cautious about that. Bone age is already advanced. So in this setting, we can think of insulin sensitization by using metformin, as was presented by Proteek in that perspective. So appropriate treatment may happen in that regards. Now, this is the study which Sayan was talking about, how early metformin therapy may delay. It's a very small study, but early metformin therapy delays menarche.